Hello and welcome to this Health Foundation webinar on understanding and using the patient activation measure in the NHS. Really delighted to be here with you today, and it's great that so many of you could join us for this session. My name is Sarah Deeney. I'm the Assistant Director of Data Analytics at the Health Foundation, and I'll be chairing the session today. Who's joining me are the speakers Dr. Katie Coleman, who's Vice Chair, Clinical Lead of Islington CCG, and Professor Natalie Armstrong, who is the Professor of Healthcare Improvement Research at the University of Leicester. As we all know, for those living with chronic conditions, the time spent with clinicians is only a tiny fraction of what goes into caring for their condition and their health. At the Health Foundation, we are really interested in understanding how the patient activation measure could be used to encourage care that was centred on the person and also encourage better support for self-management and self-care from patients. And I know that many of you who have joined us today share my interest in this. Please send your questions during the presentation by typing them into the box on the left-hand side of your screen. We will be monitoring questions as they come in, and we will start a Q&A session once we have heard from all the speakers today. So first we're going to hear from Katie Coleman, who will give a GP's perspective about why her CCG decided to pilot the PAM tool and how it helped them to plan care, plus the opportunities and challenges they faced in doing this. Thank you, Katie.
Fantastic. Thanks, Sarah. That's wonderful. So just before I kick off, I think just because I am the first speaker, I just wanted to sort of refresh your memories about what patient activation is and how we might measure it. So patient activation describes the knowledge, skills and confidence a person has to manage their own health and healthcare. And the patient activation measure is a patient-reported measure that was developed by Judith Hibbard in 2005 in Oregon in USA. And it's measured by completing a questionnaire or a tool that has 13 questions. So typically it has 13 questions, but they have refined it and sort of made it slightly shorter, but primarily we use the 13 question tool. And then it's scored from 0 to 100, and within that 0 to 100 there's 4 levels of activation. So people with a low level of activation would be scored at 1, and those with a high level of activation would be scored at 4. And what we're seeing is that those with a lower level of activation are less likely to take an active role in staying healthy and in their own care. So just to sort of set the scene a little bit and sort of give you a little bit of background on Islington, which is where I work as a GP, and the CCG that I work within. So Islington has a population of around sort of 230,000 people. There's 34 GP practices, and sort of contrary to sort of people's perceptions of Islington, people tend to sort of think about it leafy upper street. It is actually a very deprived area, and there are significant markers of deprivation with high levels of childhood obesity, children living in poverty, things like that. And also we have sort of poor health outcomes and extremely high levels of prevalence of sort of people with long-term conditions. Indeed, in Islington we have around 38 to 40,000 people living with long-term conditions. So as an area and a CCG, we have a really long history in Islington about sort of looking to embed self-care and self-management. So back in 2006, before the CCG, we had a person-centred self-management care strategy. And then as the CCG came online in 2012, I developed a sort of patient and public participation strategy, which really looked to sort of embed patient how we could support people to become far more involved in their own sort of care. So we really did sort of recognise the importance of sort of embedding person-centred care and sort of very much building on the concept of the house of care. And as we started to work through that thinking, we really wanted to identify how we could measure success, and so it was quite difficult for us to identify a measure of success around person-centred care. But I was introduced to the concept of patient activation, and so for us in Islington it felt like a real opportunity that this might then help us to sort of kind of evidence our success around how we're delivering against our own localised developed sort of I statements and also our person-centred care. So once we'd sort of decided that we wanted to use the patient activation measure, we then sort of had to think about how we wanted to use it and what we wanted to measure. So interestingly, when I first came across the measure, the patient activation measure, it very much had been obviously used in America, and the population in America is different from that in England, and often it's used within a population that's sort of covered by health insurance. And so there was something around how can we sort of validate whether this is could be utilised in England? Will it provide us with the sort of same information and sort of same evidence that actually if you've got a low level of activation, you're more likely to use services. If you've got a high level of activation, you're less. So we wanted to really validate this as a tool and sort of understand whether it was going to be something that we could use in the UK. It also been validated in America as an outcome measure, and one of the things that we'd been doing in Islington had been, as I said, to embed person-centred care, particularly for people with long-term conditions. And we had implemented a long-term condition local commission service with our GP practices, which very much involved bringing people in to have sort of really collaborative conversations with their healthcare professionals and to understand what role they could play in their own care. Just absolutely recognising, as Sarah said earlier, that actually when you have a long-term condition, you spend a tiny amount of time with your healthcare professional and actually a significant amount of time looking after yourself. So we really needed to understand whether this intervention of collaborative care and support planning would actually help people to take a far more proactive role in their care. We also work really closely with the Whittington Health, which is an integrated care organisation, and they have a strong department that supports self-management. And a couple of programs they run, so they run an expert patient program and they run a diabetes self-management program. And they were really keen to understand whether, by using the patient activation measure, whether this would be also, could evidence that their programme was effective and actually did sort of move people along activation and ensure that they were more able to sort of take a more active role in their own care. And at the same time, it transpired that there was a sort of a pilot, a sort of a study going on in the bariatric surgery department, and looking at whether sort of a more intensive support around sort of dietary advice for people who are about to enter into bariatric surgery versus sort of normal care, whether actually that helped to improve people's sort of success for bariatric surgery. And they were keen to look at whether activation had a factor in that as well. So there was a number of things that we wanted to look at as from a purpose of an outcome measure. And then we had the opportunity of working with with NHS England and the Health Foundation. And given the fact that we were looking to actually apply this tool across the whole of the population, it really did start to lend itself to sort of working with the Health Foundation, who was really keen to look at sort of bigger data. And so this really enabled us to work really closely to sort of see if there was a real opportunity to sort of understand how you can sort of commission more effectively if you understand what your population's level of activation is, and also to sort of help shape the thinking as part of the NHS England's pilot for patient activation. So once we'd sort of agreed what we were going to do, we then had to think about how we were going to implement that. And there's no two ways about it. It was pretty tricky. So we had 34 practices that we had to work with. Every single practice needed to understand how they needed to identify their patients with long-term conditions. They needed to think about how they were going to send out the letters, get the letters back, get the scores collated, put the scores on the records, ensure that all of that information was sort of collected. So it wasn't easy, and it took quite a lot of work with all of our different practices to actually sort of achieve that. But it did mean that by the end of it, because we did it twice, we did it at the beginning, and then we allowed a year's worth of the new long-term conditions service to be sort of implemented, and then we did it at the end. So it meant that we actually sort of reached a significant number of our population, and interestingly, we sent it out to 38,000, and we had about a sort of 25 to 27% sort of return rate for the survey, which was really, really excellent. And you'll hear later about how many of those patients responded twice to the survey, because obviously that was a factor that we suddenly realised that we needed to consider as well as we work through this. We also sort of worked with the Islington Health so that they could look at how they could use it as an outcome tool with their expert patient programme and then feed that learning back to the system. I think just at this point, I think it's important to recognise, and this possibly comes up with our learning, is that it's not easy to sort of like understand whether the single intervention of collaborative care and support planning was the only intervention we were measuring, and I think that's something that we need to recognise, that actually people have lots of interventions over the course of the year, and so it's difficult to know whether it was the only thing that we were measuring. But what we did find in the second, when we had the second tranche of measures, was that actually there had been a small improvement in the level of activation. So there'd been more people at level 1 at the beginning, and in the second tranche there were more people at level 2, 3 and 4. So who knows? So let's have a look. Yes, finding out, so plans for the future. So as a result of the work we did, I think that we felt that we were able to validate the tool and that it could be used in a population in England, that it did seem to sort of demonstrate, and that's something that we'll pick up later with the sort of looking at the results from the Health Foundation. I think that we're looking to sort of potentially to continue to roll it out across the population, but we recognise that was quite difficult to do it at such a large scale on a paper-based sort of survey, and so whereas the opportunity as we move into possibly integrated digital care records and shared records across the system, that we could possibly push this tool out to people as part of an electronic care record. We want to think about how we can possibly start implementing targeted use of the patient activation measure, similar to other sites that have done that across England. And we're also working really closely with sort of a health navigator service and sort of integrated networks where people are working in small multidisciplinary teams, looking at very complex and high-risk patients, and understanding whether actually by using the patient activation measure, it would help us to provide the right level of care for those individual people. So what have we learned so far? The most important thing when you start is that you know why you're going to use it. So what's the purpose? That I think it's really important that you identify the cohort that you're working with. It's really important that you know who's going to be doing the patient activation measure and where in the pathway. I think there's something about how people are going to use the results, the score, and that people have had the training so that they can have a good conversation with patients. I think there's a risk that if people base their work around a score and don't think about actually listening in a conversation, that actually there's a risk that you miss what's important to the person. I think that there's a real opportunity of sort of as I said, doing this electronically and sort of like looking at how we can use it to reduce cost. And I think it's really important that once you know, if you are going to use it for tailoring, that you are really clear about the services that can be used for each different level of activation. And finally, I think it's important to recognise that people get lots and lots of questionnaires, and that there is a risk that if you keep sending out questionnaires that people will experience questionnaire fatigue. So lots of learnings and sort of lots of opportunities, and for us it is still very much at the beginning of the journey, and we are looking at how the other sites have used it to see what we can implement locally.
Thank you so much, Katie. So that was such a fascinating insight into your experience of using PAM, and I think really showed the scale of your ambition from the start, but also the challenges that you faced, and that it is part of a journey, and that there is lots to learn from everybody else who's using it within the system. And one thing to mention is that that's why we want to get your questions coming in, and I can see there are some good ones coming in, so please do keep them coming. But now, I'm going to present some work that Katie has already sort of introduced for me about the patient activation measure that we did in the Health Foundation. This was a piece of data analysis work. And I know that there's been a lot of interest from it, from those I've met in CCGs, because until now we've really only had to look to the United States to try and understand the relevance of self-management capability and or activation when we look at how patients use the health service as a whole. And so Katie's already really well introduced what patient activation measure is, but I'm just going to remind us that it has 4 levels. So patients at activation level 1 are the least activated, so those people might be quite disengaged from their own care, whereas those who are at level 4 are going to be almost the expert patients. So hopefully we've all come across people like that. And those who are people we really expect to be engaged in their own care. And I'm just reminding you of this is because when we did our analysis, we looked at the different levels of patient activation rather than looking at the point scale between 0 and 100. So it's just to remind us all where those numbers are. So, as Katie mentioned, we work quite closely with Islington CCG to do some data linkage. So we know that what they did was that they sent the patient activation measure as a paper questionnaire from people's GPs, and they were asked to send them back to general practice. Then general practitioners recorded that on the patient electronic patient record. That was a really important step for us because it meant that we could then link the electronic health record that had the patient activation level for each patient to all their care within the health economy. So it means that when I present my results, we can have information for both primary and secondary care, and also outpatient A&E use is other things that we looked at. So it's really the first time that we've had a very comprehensive look at the impact of activation across the health economy and not just focused on secondary care, which I think is of particular interest for those with chronic conditions, given how important primary care is in keeping people healthy. So we had an awful lot of data to work with. It was amazing. I think it's a real testament to the engagement of the GPs within the CCG in Islington that there was such a good return rate. And it's something that they can be very proud of. And actually, when we did an analysis of which patients were more or less likely to send the questionnaire back the second time, we found that those patients who did visit their GP more versus visiting the A&E more, or secondary care more, were more likely to send a questionnaire back. And just a little word of caution, more activated patients did seem to be more likely to send a questionnaire back. So ideas and questions on that later would be really welcome. So because we're able to link together the primary and secondary care data, we could get a really rich picture of what the population was that we were looking at. So hopefully you can see these are our little personas. So we had 4 different levels of activation. We had a relatively young population in terms of those people who have chronic disease, quite multimorbid. So most people had at least 2 long-term conditions. And a lot of people also had a comorbid mental health condition, which is quite important, I think. And the most common level of activation was in level 3. But as you can see, quite a young population, but not really much difference between male and female. That's what we'd sort of expect from that population. So what we did was we built a large regression model that controlled for all the patient characteristics that we could observe within the electronic health records. And we were able, because the health records were so comprehensive, to look at a number of different outcomes, which is what I'm going to take you through here. So we looked to see whether the PAM level was a predictor of the utilisation of different parts of the health service, controlling for our patients' chronic conditions, deprivation, age, and so on. So the first one that we have up is looking at general practice attendance. And I think what's really interesting is we can see that there's quite a big difference between those in PAM level 4, so the activated patients, and those who are level 1, so that's who we're comparing against. So compared to the least activated patients, the most activated patients go to their GP about 18% less. Which is quite a big difference. And I think probably important to an awful lot of the people who are implementing care changes for those with chronic conditions, because it shows that not only, and I'll show you in a second, might there be a benefit in improving self-management for those who attend secondary care, but there also might be a benefit to the actual total number of attendances in primary care as well. And so then, as I mentioned, if we looked at difference in A&E attendances, this was even greater. So we saw that there was a 38% difference between the least activated and the most activated when we looked at those who attended A&E, which is really quite substantial and in line with what we were seeing from the United States, which I think is interesting in and of itself. Then when we looked at, we also wanted to look at measures that we could pretty confident would be perhaps an inefficient use of the system. So there might be very good reasons why people need to attend A&E. There are very good reasons why people need to attend a GP. It might be difficult to cut those down. So what we did was we looked at a few different measures that we thought came to a consensus might be avoidable or undesirable, and those were things like did not attend at general practice, and we saw a difference in the rate of change between the lowest and highest activated when we looked at the did not attends in general practice, and then also the rate at which people were going to A&E for a minor complaint. So again, about a 30% difference between the lowest activated and the highest activated in attendance at A&E for minor complaints. So those are things that we think should probably be handled within primary care. But a question I often get asked about PAM is saying, well, that's all very well for people with chronic conditions who don't have a mental health condition, who aren't from a deprived background. What's PAM got to do with those groups of patients who I know perhaps need my service more than others? And so because we had such a large data set, we were able to break the population down into subgroups. And what we found was actually really interesting. So the first slide you have up here is about those with a mental health comorbidity and those without the mental health comorbidity. And what's really interesting is that actually activation is more important for those with a mental health comorbidity than those without. So you might actually get greater gains if you have a patient with mental health comorbidity and you can improve their self-management. So I thought that was incredibly positive and hopeful. Interestingly, when we looked at patients who were over 75 in the cohort, what we found there was activation seemed to be a little less important, and we couldn't really get a clear signal as to the impact of activation levels, which we found very interesting, and there could be a number of different reasons why that might be the case. And then finally, Katie mentioned that she has a population that's very deprived compared to the English average. So when we looked at the most deprived population compared to any other area of deprivation, we found was that patient activation measure was actually really important in those. The activation level was very important, even if you did come from a deprived area, suggesting that there are improvements that could be made for patients from deprived areas if we could improve their level of activation, which again I think is very hopeful and a point of optimism for us all to think about. So I suppose there are some study limitations that I do have to mention. This was a data analysis where we were looking at administrative data that had been collected to provide care, so it doesn't have absolutely everything you'd want to look at. So there could be other patient characteristics that we haven't controlled for, such as disease severity, the educational level of different patients, and maybe also the social support that they have around them. So we don't know what kind of economic circumstances that they might be in, or what kind of family support they might have around them to help them with their care. There's also an open question as to if you live in a different population with a different population structure and perhaps a different area, are our results generalisable to those CCGs? And I think more studies need to be done so that people can tailor their understanding to their own area. And also importantly, we didn't do a causation analysis, so we can't say from this analysis whether a change in PAM level will definitely result in an increase in utilisation. We need some, or decrease in utilisation should I say, we need some prospective studies that actually look at that, and hopefully we can discuss at the end how we might build that sort of evidence base. However, our results did suggest that there are quite important clinical implications. So studies or interventions that enable patients to better self-manage could have an impact on reducing utilisation across the whole health economy, so in primary and in secondary care, which, given the pressure that GP practices are often under, as well as their colleagues in acute care, is going to be very important, I think, as going forward. But I think there's also a need to gather further evidence about what interventions are going to be best for different groups of patients to improve their self-management, and how, importantly, do we help doctors and other clinicians working with patients implement this. So that's what we have from our data analysis, which is just part of what we wanted to look at with PAM. And I'm going to pass you over to Natalie Armstrong, who's going to introduce the qualitative analysis that they did in multiple different sites. But I'm just saying that we're getting some really great questions still coming through. So just to remind you to keep them coming, and I'm sure you're going to have some questions from Natalie once she's finished her work.
Okay. Thanks very much, Sarah. So what I'm going to do is broaden things out a little bit, because we've heard sort of two examples largely based in Islington CCG. And what I'm going to do is talk you through sort of high-level overview summary of a piece of qualitative evaluation work that we were commissioned to do that really looked at organisations experimenting with piloting use of the PAM across the NHS. So we've already had quite a lot of coverage about some of the potential benefits that there might be for both patients and for healthcare services in improving patients' activation levels, because there is some evidence that suggests just that those improvements can be made and that they can be maintained over time. And I won't sort of reiterate, but we've had already some discussion of the benefits that there might be in terms of patient outcomes and levels of healthcare utilisation. And there's been quite a lot of interest in the concept of patient activation and in its measurement in the UK over the past few years, due in part at least to this report from the King's Fund from a little while back now, co-authored by Judith Hibbard, really looking at introducing this concept of patient activation and sort of trying to set out what the benefits might be of engaging with this as a concept and of using it within the NHS. So what NHS England did was to bring together a learning set of 6 organisations, 5 CCGs, of which Islington was one, and the UK Renal Registry, and gave them support, gave them licences, sort of brought them together periodically as a learning set so that they could share their experiences of using the PAM in practice, as Katie suggested, share some of the challenges that they're experiencing, see if they could sort of help each other out with thinking about ways to tackle some of those. So what we were asked to do by the Health Foundation and NHS England was to work alongside those 6 healthcare organisations, which we did for a period of around 2 years, and to do a qualitative piece of work which really tried to understand how they were using the PAM in practice. So what exactly were they doing with it? So the learning set wasn't prescriptive in terms of what the organisations had to do with the PAM, how they had to use it, who they had to use it with. It was for them to make decisions and to build strategies locally as to what they thought was going to be the best way forward. So we wanted to ensure that we captured how they were using it, and whether and how that developed over time. So whether, for example, they set out with particular intentions and then for all sorts of reasons perhaps changed direction, changed focus, and how that played out. Also looking at the impact of using the PAM within participating organisations, and I don't mean in terms of kind of quantitative impacts, but more in terms of people's experiences, people's perceptions, how people were responding to being asked to use the PAM, both in terms of healthcare professionals and patients. To think about, I've said here, explicating the mechanisms of change. That's because I'm a social scientist and that's the kind of language I use. But really thinking about, okay, well, if it looks like there is being some impact here, how's that happening? How's that being brought about? And we gave formative feedback to the learning set quite regularly, and we've produced several reports, which I'll tell you about in a little while. And we're sort of engaging with webinars like this to kind of share that learning a bit more widely. This is just a very, very high level picture of what we did, just so you can sort of put what I'm going to tell you in a minute into context. So we worked with the 6 organisations over a period of about 2 years. One piece of work package 1 on the left, was focused on the core teams within each of these organisations. So the people within the CCGs or within the disease registry who were making the decisions about how they were going to use the PAM, which patients they were going to use it with, which kinds of services they were going to embed it within. And we worked with them longitudinally, as I said, and thinking about asking them what are you doing? How are you doing it? Why are you doing it like that? With what outcomes? What are you seeing happening about that? And as I said, really important there to think about what changes there might have been over time. But then alongside that, we also worked with a purposive sample of 6 of the projects that were going on across the learning set to look really at the frontline level, so from the perspective of frontline healthcare professionals and patients, to look at actually what happens in practice when this tool is used. How is it being used? Why is it happening in that way? To look at staff perspectives and, importantly, of course, patient experiences. And we did that by observing at learning set events and within projects themselves. So we went along to training sessions and project meetings and also observed in clinical practice. We did interviews with core staff within organisations, with frontline staff and patients. We looked at reams and reams and reams of documents, whatever the projects would give us. And I should say actually a big thank you to all of them because they were fabulous in giving us access to the kind of data that we needed. We analysed that and we've written various reports. This is an enormously busy table and I don't expect really anybody looking at it cold to get very much from it. I have to lie down in a darkened room really whenever I think about it. But what it's really showing is that across the 6 organisations in the learning set there were really quite a lot of projects ongoing. So most organisations had 2 or 3 or 4 pieces of work going on. So it wasn't just, one way of using PAM in each case. But you can see that there was quite a lot of variation in the scale of these projects. So some were really quite large, some were much smaller. There were different kinds of interventions that were being used. So, for example, health coaching or structured education, those kinds of things. There were different kinds of patient groups that the different CCGs were working with, different kinds of provider or healthcare professional groups as well, and different ways in which the PAM was being positioned. And Kate has already made mention a little bit of the kind of difference perhaps between as an outcome measure or as a tailoring tool or as a commissioning support tool. So it was very, very clear, and you would expect this because the learning set was really, people self-selected into it. There was a lot of keenness around using the PAM. There was a lot of perceived alignment with work that sites already had going on around person-centred care. It very much seemed to fit in with the direction of travel. But importantly, to fit a gap in the toolkit, particularly about being able to measure and to quantify what had, up till that point, felt quite slippery, intangible concepts. And I think, Katie, you made mention of this. A lot of the people within CCGs talked about the benefit of being able to measure and to quantify for use in business cases and that sort of thing. There was a lot of appeal because it was a generic rather than a disease-specific tool, and of course it was sort of being endorsed by NHS England through the learning set. And one of the things that we were very, very keen to really try and bottom out with the sites that we worked with was this idea of logics of use. So how is the PAM being positioned within the work that they were doing? What functions did they want it to serve? Did they think it could serve? And how were they going to ensure that it served that purpose? And what did they need to do around it to make sure that that happened effectively? And we saw that there were really, I suppose, there were a couple of main logics of use that we observed. One was as an outcome measure to look at either a population or a service or an individual level to say either, okay, so across our population, if I'm a commissioner, across our population, what's the sort of breakdown of the activation level of our patients, and what does that then tell me about how well we're doing and how well we're performing? Or at a service level, so for example, if you've commissioned a health coaching intervention, what you might want to do is say, okay, well, before people start the intervention, we'll look at their activation level, and after they've completed, we'll do that again. And then perhaps we'll be able to say something or draw some conclusions about the value of that service and whether we should be looking to recommission it. Or at an individual patient level to see how a patient's doing and to see whether they're being supported appropriately. Against the sort of outcome orientation was the use as a tailoring tool, and that could sort of function in a couple of main ways. One would be at the sort of population or service level, so to say, okay, across the piece, across our population, what kinds of things do we need to be commissioning? What kind of services do we need to have available for our population? And can we say anything helpful about roughly kind of what proportion we need to have? So, do we need to have X amount of health coaching available? Do we need to have X amount of self-management support through structured education or whatever it might be? But also there was a lot of interest in using the PAM and the data it provides as a tailoring tool at the individual level. either within interventions, so to know what kind of intervention or further support to signpost a patient towards or actively refer them into, but also within interventions. So for example, within health coaching, there was an idea that data collected via the PAM could be really helpful in thinking about how you work with that patient, perhaps what might be some of the most obvious points of contact or points of content that you might want to go to straight away. So for example, there's a question in the PAM about understanding medication. If patients aren't answering that very positively, then that perhaps gives you an obvious place to start. And what we noticed across the sites was that quite often those uses were being blended, sometimes quite deliberately, but sometimes sort of less deliberately, and there was perhaps an element of kind of muddling them and not really unpicking, well, can it serve both of these functions perhaps in the way that we think it will be able to. This is a picture which really just sums up implementation to my mind, and Katie sort of hinted at this already. I think all of the sites found it more complicated than they had anticipated to get started. I don't think any of them were as sort of quick out of the blocks as they had thought that they might be. There were issues around governance, around data, around having systems in place to make sure that the data was collected and got to where it needed to be. There were issues about, well, who can have access to the data across a health economy? Where can the data flow? Do we need consent from patients to do the kinds of analysis with the data that we might want to do? And sites sort of talked a lot in the interviews we did with them about having to develop workarounds and sort of find quick fixes which weren't really ideal, but they just had to work with. We also found, certainly in our frontline work, quite a focus on completion of the PAM, so not in the kind of postal way that Katie's talked about, but within consultations, where the guidance from the tools developers is that that should be sort of very clean and very detached, sort of use or quite close adherence to the language of the PAM with only minimal variation. And we saw actually quite a lot of deviation from that, quite a lot of mediated completion happening, sometimes for what seemed like very, very good reasons. Not least because efforts to avoid that could be very difficult interactionally if you're, as a health professional, not responding to requests for further discussion or clarification from patients. That can feel quite uncomfortable. So mediation occurred for quite a range of reasons, and it's important to say that it wasn't just language that was the problem here. That was the case in some instances, but very often patients they wanted help interpreting the questions and knowing how they should be orienting towards them and how they should be answering them. And it wasn't always obvious what kinds of patients would need help completing the PAM, nor how long that would take, and we saw that varied quite a lot. And of course there are different translations available, but it's not necessarily so straightforward as just producing a version of the PAM in the appropriate language. That's not always going to be the solution to the problem. In terms of patient and professional responses, patients were typically either largely oblivious to having completed the PAM at all. There was lots of sort of discussion about, well, you know, if I fill in lots and lots of forms, I can't really remember exactly which one it is you want to ask me about. One of the patients we asked for an interview said, well, I'm happy to talk to you, but you'll have to tell me what it's all about because I don't remember doing this at all. Or they were sometimes quite negative. So there was a lot of uncertainty amongst some patients about activation, in terms of the language and what it meant, about the PAM itself and how they were supposed to be answering these questions. And what the whole thing was all about, certainly for some patients, there was a sort of sense of suspicion about, is this about assessing my benefits, or, you know, is this seeking to make some kind of judgment about how hard I'm trying? Professionals were more mixed, so there were a lot of enthusiasts, particularly within the CCGs and the organisations, but also some on the front line as well. There was a lot of enthusiasm for its tailoring potential, a quick way to assess patients, particularly if you don't know them very well or perhaps you haven't even met them before. The benefits of being able to monitor progress and to use that to motivate patients and to identify key areas to focus on. But I think it's important to say that we did also encounter quite a lot of sceptics who thought that it was, as a tool, it's too lengthy, too complex, that it wasn't a substitute for knowing the patient. We had that quite a lot, particularly from people who felt they knew their patients very, very well. They didn't see what value this added, certainly for them and what they were doing with patients, and not understanding the data and what it was showing. So these are the key sort of summary points from our evaluation. I think I've covered most of them already, and some of them have already come up through the other presentations. But if you would like to learn more, then what I've done here is put a little bibliography. These are all the reports that we've produced so far, and the links in the slides should be active, and all of those should be available, open access for people.
Fantastic. Thank you so much, Natalie. flip over here. As Natalie mentioned, all the full findings of her really interesting research is available now online and freely available for anybody to look at, and I'm sure we'll be happy to answer any questions that are coming up. And I think what all the presentations shown, but I think Natalie's really managed to surface was just the breadth of work that is happening around PAM within the community. I think the cautious enthusiasm that there is for it, that it's seen as being a potential really useful tool if we can just crack how to use it. And so I think it's really great now that we've got some time for questions from people, and I can see some really good ones coming in from you. So, but do keep them coming, because there's still time to ask questions. But I think we'll just start with one to get us going. And it's about essentially, now that we understand the potential of activation, what do we need to do to build the evidence base so that we can start to design interventions that can use it in practice? And I've just kind of ask Katie from a perspective as, I suppose, a clinical lead, but also a GP as well.
Yeah, so I think, I think it's a really, really good question, and certainly when we sort of kicked off the learning set, I think there was a lot of sort of questions about, well, if someone is a level 2, what does that mean, and what intervention do we do, what do we offer them? And over time, we have sort of seen some sort of recommendations around if you are this level, then these are the types of interventions that you might find useful. And I believe there have been some posters that have been developed that actually sort of try to collate that information. So a level 1, you want to work in this way, a level 2, you want to work in this way. And that's certainly something I'm sure that we can sort of share later as part of the information to share out with sort of people who are listening. I think the other thing that I just want to mention is that the Sheffield site, so Dr. Ollie Hart did a lot of work and has sort of really sort of taken this forward in Sheffield, and he's sort of developed a bit of a quadrant sort of method, which really allows you to sort of, as you get as you understand someone's activation level, it then enables you to target your intervention within a practice. So not only sort of like utilising community services, but how you also use your services within a practice, and actually where you would possibly where it would be a practice-based service compared to maybe a more sort of care coordination service where there's greater interventions and support. And I think that that's a really useful sort of way for practices to be implementing. So I think there's a lot of learning that's coming out of this, and certainly something we can share.
Yeah. And I think that's certainly interesting, and it ties into one of the things that we heard a lot, particularly from frontline staff, which was they really did want to feel that that link was very much there. So if it looked like their patient was an activation level 2, what did that mean? And they wanted to know, of course, that there were services available locally that existed that they could be referring patients into. So I absolutely agree that that's something that felt really important. But also what I think it's important to be sort of conscious of as well is that, yes, it's helpful to know where you might be most appropriate to refer particular patients, but also that it doesn't potentially come in as some kind of gatekeeping or eligibility criteria that, you sort of, well, if you've got a patient saying, oh, I'd really like to go on some kind of structured managed self-education support course or something like that, that you kind of say, well, I'm afraid you can't do that because you're in your PAM level 1 and perhaps that's not appropriate for you. So it's just being aware that it can be helpful, that it doesn't become...
How to handle it delicately.
Yeah.
And I think from a commissioning perspective, I think it's really important for us to be absolutely mindful of the types of interventions which are sort of successful, so that we can then continue to sort of commission those services. And there actually will, there's a real opportunity for us to be sort of kind of commissioning more community-based services of things which will really build those local assets and sort of ensure people are much more grounded in their local communities. So like peer-to-peer support groups and cookery classes and things like that, which actually are what people with sort of, long-term condition often need, because it's all about behavioural change, and actually will sort of again help to sort of address the resource issues in sort of in the NHS.
Yeah. And I think from a data perspective, I think having those conversations about what works becomes an awful lot more easier if we start to build population sizes where we can actually tell what works. Because I think as you're dealing with sometimes quite small numbers of pilot programs, it can be quite difficult to tell whether to a level that we would be happy with in terms of an evidence base, whether there has been change or whether that change is just due to chance. And I think that what we do need is to we can use data linkage to really understand the patient's background and what they've done before, and whether that behaviour has changed after an intervention or not. And I'm really hopeful that as we sort of bring together more work in this area and the numbers of people who have received interventions grows, we can start to be able to understand what's actually going on and what's effective or not, and hopefully build a case so that you can make a business case if you need to make a business case, or explain to patients, well, there has been evidence that actually for different types of patients in different circumstances, this might be a more appropriate intervention for you rather than that one. Because at the moment I think people are doing their best but going off perhaps intervention studies that have not been done in the UK yet. And
I think it's interesting thinking about the sort of, this is a question that we, or an issue that we talked about with the sites quite a lot, particularly around there where they were trying to use it as an outcome measure, was to think about, okay, well, what kind of time period would be appropriate to do that kind of evaluation over, and what kind of change in activation level is a good change and is a significant change. And I think, I mean, we didn't really have any helpful answers to give them. But, you know, and I remember, I think it was the health coaching service in Horsham, they found that there quite a lot of patients that they worked with actually had a bit of a dip in their activation level, and then it sort of started to come back up again. So there's, you know, there's that classic thing about it depends when you measure and what you regard as sort of appropriate for that time period.
Can I ask, Natalie, what were the outcomes that teams wanted to achieve? So we saw, I suppose, from the data analysis we did in the Health Foundation that there was potential that it could hit different levels of the health economy. Was there a particular sense in different sites that they were looking to change utilisation or change the way patients behaved within the population, or were there different focuses?
There were different levels of focus, and I think that's one of the really nice things from our perspective, although it made it quite challenging to do on the ground, that people did have different sort of orientations towards that. One of the things that we saw quite a lot was wanting to avoid things like unplanned admission to hospital and that sort of thing. So really wanting to focus on particular patient groups who either were in that space of having lots of unanticipated trips to A&E or hospital admissions, or looked like through some kind of risk scoring that they might be on the cusp of sort of slipping into that pattern of healthcare utilisation. And there was certainly some sites which really wanted to try and be supportive to patients to sort of help them come back from slipping into that position. So, but there were quite a range of outcomes that the sites were interested in.
And from your experience of working with teams in primary care, implementing these measures, what is the useful feedback for them from using the measure, and can we get better at feeding data and outcomes back to people working on the ground who are actually implementing the services? Sorry, big question.
So I think it's really, and I think it's a difficult area to consider. So as I said, in Islington, we the outcome, the level, both the score and the level was sort of embedded in the electronic health record. And particularly for some patients, particularly people with long-term conditions, they're utilising the services quite a lot. And so it's about where do you store that sort of information as a sort of, and have the people who are going to be using that as part of a conversation or as part of their sort of contact with that individual. Do they have the training around utilising the patient activation measure to know to go to look for it in order to then to help them with their sort of how they might then tailor their intervention? And that's not what we were looking to do in Islington. We were looking primarily to sort of as a measure of outcome. So we didn't actively sort of do the training around what is patient activation measure and how should you do it. So I don't think we have the experience in Islington to say how people would use it at a sort of at the coalface. But I think it is, and I think that just then comes back to the point about actually when you're having a conversation with an individual, if you're listening effectively, it becomes quite apparent where they possibly are on that trajectory. And it's, you know, I think that not everyone's as effective at understanding where that person might be, but you do tend to sort of get a good, have a good guess about where they might be and therefore how you can sort of support them. But they didn't really use it directly in sort of general practice. And that was much more used with the tailoring, I think, wasn't it?
But what was interesting was particularly for some of the frontline professionals that we were talking to who felt that they knew their patients really well, they quite often felt that they saw a bit of a disjuncture between their assessments of the patient's activation levels or their engagement and what they were getting officially from the PAM. And I think if they saw that discrepancy, they were, they just went with their own assessments.
Right.
And perhaps that's because they were sort of sceptical about the tool more broadly, but they certainly felt that they would always prioritise their own assessment of a patient over what the PAM was telling them.
And just related to that, actually, I think this is perhaps more for Natalie, given how you've used PAM in your service. But we've got this great question about how long should a PAM appointment be? Do you consider getting patients attending the clinic to complete the PAM? And actually, because you used it by post and are talking about maybe using it differently, I'll ask you first whether there's any experience of that from the pilot studies of using it in service, and then maybe get Katie to jump in.
It's actually really, really interesting because is the language of a PAM appointment.
A PAM appointment.
I think that's really interesting because
really
we didn't, the PAM itself is not an intervention. It's not something to have an appointment around. And we saw lots of different ways in which it was embedded around healthcare services. So one particular example is the telephone health coaching in Horsham, where it was done sort of very quickly and cleanly at the beginning of an introductory session, where it was done quite straightforwardly, and there they really didn't sort of deviate from the specific wording. Or we saw it being completed with healthcare assistants as part of a much bigger diabetes annual review, and sometimes that could take quite a long time if the person doing that was quite willing to have lots of discussion and help patients think about how they would respond to the questions. So, that could take a lot of time, but, arguably that's not how the tool's developers would say that you should be doing it. But again, it comes back to what do you want to use it for and what information do you want to get out of it? And sort of doing that much more detailed discussion and really unpicking people's responses will inevitably take longer.
So I think that it's interesting, this PAM consultation. So I think that, so as I said, the most important thing here is about delivering person-centred care, and we, as I said, lots of people are interested to know whether this helps people to understand where people are at in that sort of trajectory of being able to be more, look after themselves. And a PAM consultation, when we have collaborative care and support planning in general practice, it's definitely a 20 to 30 minute consultation. It's about having a good conversation with someone. It's not about sort of like, and actually teasing out from the individual what's important to them. And then as a result of identifying what's important to them, well, what support do you need, or what support do you want in order to achieve that goal that you've identified as being important to help you stay healthy and well. And I think that's possibly what the person maybe means in regards to a PAM consultation. And
Yeah, it's interesting to see the language changing over this, I think, because I remember when I started to work on this, I didn't know what anybody was talking about when they talked about activation. It's been a bit of a journey, and I think I'm increasingly finding as you go out and talk to different people are starting to understand that word. So it's just amazing that we now have a PAM consultation is coming up as a term. So we've got a question about the data, which I'm delighted about, obviously. So it's a great one about how we assessed whether there are any biases in the data, and then other than how the data was collected. So we did do a study looking to see who were the patients that were more or less likely to send the postal questionnaire back. And as I mentioned, it was people who attended the GP more, the patients who were slightly older, and then the patients who were a bit more activated were more likely to send the questionnaire back. So we're aware of that. In terms of the biases in the data as a whole, I think that because the data was collected as part of the electronic health record, and so it's collected as part of routine care, and we did control for individual GP variation, I think there should be relatively little biases in the data itself and how it's collected, because it wasn't collected specifically for this study, which comes with its own problems. And so we were able to control for a wide variety of patient characteristics that might confound our findings. But I think we could acknowledge that a perfect study would have also collected some individual level patient data and maybe practitioner data about their other attitudes and behaviours that aren't collected in the electronic health record. So there's always more work to do there, and would be delighted to see more work on that, particularly I think on educational level and deprivation and social support and understanding how that affects patient activation level.
And we had thought in Islington, because you know, one makes these hypotheses and you wonder, so you think, activation, are we going to see less people responding who have who are depressed, mental health problems? And that was a real concern when we were sending them out via postal survey. And we did sort of, for a period of 6 weeks, also ask practices to hand them out to try and get to capture a wider sort of cross-section of the population, because we were worried that we weren't going to maybe capture everybody, because lots of people don't open letters, particularly if they're particularly depressed things. So there was that desire, but I think there was probably less activity from the practices around handing them out. I think it's, practices are very busy, and at times it can be difficult for them to remember to do all the things that they need to be doing. But I think it's something. I think it's something to be considered. So how do you reach everybody if you're going to take this approach?
Take this approach. And I think there's another question that's just come through about deprivation, and that whether it's strongly correlated with PAM, and that was something that we were very interested in not only controlling for in the model, which we did in those frontline results that I presented, but also looking at the way it was interacting with PAM. Because we know, as the questioner rightly points out, that there's a strong relationship between deprivation and healthcare utilisation. And we actually found that once you looked at the subgroup of the most deprived, you actually seem to have more of an effect of PAM and patient activation level than those who were in the less deprived groups, which I was certainly something that I was not necessarily expecting to find, and I definitely went into it with a very critical mind, assuming, as the questioner did, that there's going to be this very strong correlation, and perhaps PAM is just talking about elements of deprivation. But Katie, as a GP, when you see patients coming in, and you obviously have a very deprived population, what is your sense of how activation looks like happening when you're in a deprived community?
So I think there's a spectrum. I think that I don't know if deprivation itself is the only sort of factor. I think there's so many different contextual factors that are impacting on it that actually you can't just say it's deprivation. But what we do know and is that if you are, and what has been shown in the US, is if your level of activation is low and you are then provided with an intervention that helps you, that you often, those people with a low activation, if they can be supported, can actually gain the most. So they can be moved along a much faster trajectory. And then you can start to sort of see where there's an opportunity to sort of ensure that you're using your services most effectively. So
that's great. Yeah, it's so interesting. So I'm afraid we've reached the end of our session, and that's all the time we have today. So thank you to everybody who sent in questions. We really appreciate it. I really had a nice discussion. So we really enjoyed ourselves. Hopefully you found it useful. Big thank you to both Katie and Natalie for joining us today. It's always so great when people can take time out of their schedules, which are very busy, to share learning with everybody else. And I think it's really important. But we very much appreciate you being able to do that. And I think we've all found it an interesting discussion. I know I have anyway. And just a reminder that Natalie's evaluation is available online for anybody who wants it, and the results of the quantitative evaluation that I presented some of are going to be available over the coming months in a series of publications, which will all be available on the Health Foundation website, and we will collect them together with this webinar, which will also be available online for anybody who wants to watch it back or send it on to other people who would like to watch it. And so if you'd want to find out more about any other upcoming webinars at the Health Foundation, then please do go to the Health Foundation website. Thank you for joining us, and goodbye.